Hello everyone, my name is Meera Patel and I'm a PGY1 pharmacy resident at Emory St. Joseph's Hospital in Atlanta, Georgia. Today I will be presenting to you all on the evaluation of efficacy and safety in low-dose versus high-dose prothrombin complex concentration in post-cardiothoracic surgery patients. My co-investigators and I have nothing to disclose. Beginning with some background, incidence of massive bleeding during CT surgery can be associated with poor outcomes. In particular, patients undergoing repair of aortic dissections have an increased risk of bleeding. Patients commonly receive fresh frozen plasma, also referred to as FFP, and/or prothrombin complex concentrate, referred to as PCC, postoperatively for bleeding control to reduce the use of perioperative blood transfusions. Utilization of lower doses of PCC has the potential to be as efficacious as high-dose PCC, making it an optimal choice. In regards to both PCC and FFP blood products, PCC on average contains vitamin K-dependent clotting factors and less volume in comparison to FFP. FFP therefore results in a much longer infusion period and difficult administration in patients with heart failure or renal disease. Aside from the differences in volume, blood products do carry a risk for bacterial contamination. PCC may be associated with less use of other blood products, therefore decreasing overall infection risk in patients. However, data regarding appropriate dosing of PCC for coagulopathy is variable. Looking at previous studies, a 2012 study evaluating cardiopulmonary bypass patients at various PCC doses showed no differences in bleeding. Other studies have found PCC as beneficial over FFP for treatment of postoperative bleeding. Thus, data reveals that PCC may be an advantageous option due to its increased concentration of clotting factors, rapid reversal, and reduced blood transfusion requirements. Prior to October 2019, Emory St. Joseph's Hospital utilized high-dose PCC for CT surgery due to provider-specific practices. After October 2019, the dose was capped within the OR and practice transitioned to use of low-dose PCC for CT surgery, allowing for potential cost savings. At Emory St. Joseph's Hospital, PCC is stocked in the OR. For anesthesia use, it is dosed at 2 to 3 times 500 units, with approximately 1,000 units for patients less than 70 kilos and 1,500 units for patients greater than 70 kilos. At our institution, pharmacy was allowed to auto-sub to a new dose based upon their calculations. PCC on average cost approximately $1,000 per 500 units. This study was a single-center study performed at Emory St. Joseph's Hospital, a 410-bed community tertiary care hospital in Atlanta, Georgia. Emory St. Joe's is a Level 1 emergency cardiac care center with over 500 CT surgery procedures performed in 2020. The purpose of this study was to compare efficacy and safety of low-dose PCC versus high-dose PCC for post-CT surgery coagulopathy. As you can see, our institution administered high-dose PCC at 25 units per kilogram, with a dose cap in October of 2019, in which low-dose PCC was administered at 15 units per kilogram. The primary objective was to compare cumulative red blood cell product transfusions the day of and day after CT surgery. As you can see, secondary objectives are listed, including cumulative doses of blood products, chest tube output, PCC units used and doses administered, washout required, mortality, cost, and more. This was a single-center retrospective chart review. A total of 204 patient encounters were evaluated, of which 96 encounters were eligible for inclusion. Inclusion criteria included adults greater than or equal to 18 years of age, with exclusion criteria including those with hypercoagulable conditions and anticoagulant use within 2 days. The study assessed CT surgeries performed between May 2019 to April 2020. Of these 96 individuals, it's important to note 78 patients, approximately 81%, had aortic surgeries that were performed. Descriptive statistics were assessed via 2 statistical analyses, including Welch II sample t-test and Fisher's exact test. Looking at baseline demographics, overall both groups were similar in terms of age, gender, and race. Majority of patients were Caucasian males greater than 60 years of age, with no statistical differences between groups. Further comparing baseline characteristics, what we see here is that both groups most commonly presented with hypertension. Looking at the primary outcome, the high-dose group used more red blood cell transfusions in comparison to the low-dose group. However, this was not statistically significant. Looking at median values between the groups, there was a difference of 2 units. These values listed in the left-hand columns are medians. Due to the smaller sample size, these values allow for a better interpretation. Outcomes such as platelets and FFP used tended to be higher in the high-dose group with statistical difference highlighted. This data reveals low-dose PCC was associated with less blood product usage overall. Other outcomes such as chest tube output, total PCC, and PCC doses used statistically differed in both groups. Although not statistically significant, overall ICU length of stay was shorter amongst those who received low-dose PCC, which may be clinically significant for patient outcomes overall. On average, we see high-dose PCC was estimated at $4,200 and low-dose PCC was estimated at $2,200. Looking at the incidence of mortality, more patients with low-dose PCC were alive in 30 days or at discharge, and regarding washout, this was significantly higher in the high-dose group. Here I've included a visual of mortality. You'll notice a higher incidence with high-dose PCC. Regarding thrombotic episodes, we see there was no statistical difference in outcomes. However, with ROTEM application used within 2 hours of dose administration, there was a higher incidence in the high-dose group. In conclusion, lower blood product usage was shown with patients who utilized low-dose PCC in comparison to high-dose PCC for CT surgery-related bleeding. Although the results showed significance, the study does have limitations that may have contributed to these outcomes. Limitations of this study include, this is a single-center retrospective chart review, meaning data may be prone to some error. Power was not met in the study. Due to a small number of events, effects were harder to detect. Also, we see that short-term risk scoring scale, a critical illness severity scale, was not consistently documented for all patients. Therefore, all patients cannot be assessed for severity of illness, making it difficult to discern if sicker patients were associated with dose adjustments of PCC. Based on the results of the study, low-dose PCC is as safe and efficacious as high-dose PCC. Low-dose PCC was associated with less blood product usage, lower mortality, and less washout. Perhaps these results are applicable to other hospital sites performing similar CT surgery procedures. Low-dose PCC is also cost-effective. On average, we see high-dose PCC was estimated at $4,200 and low-dose PCC at $2,200. There is a need for future large randomized control trials, which can provide more power and assess a variety of patients. Patients within this study may have been sicker due to most patients requiring aortic CT surgery procedures. Future studies may benefit also from consistent STS scoring. I do want to point out that future evaluation of data can be reassessed to evaluate underlying variables that may have affected the results of the study. For my self-assessment, I'd like to ask, is a lower dose of PCC as safe and efficacious as higher doses? Based on the results of the study, the answer is yes. Please feel free to ask any questions. Thank you.